So in our care planning for patients with venous disorders, we want to make sure that their pain is well controlled and relieved. We want to decrease their edema to prevent any subsequent skin alterations or unwanted pain from the edema. We want to help the patients manage their medication to prevent any bleeding complications. And we want to early identify or prevent the progression of the venous thrombosis to a pulmonary embolism or embolus. So some interventions that we might do is to assess our patients at risk for blood clots. Is it a venous stasis problem? Is it an endothelial damage, an inflammation, irritation of the wall lining? Or is it an increased risk for clotting related to a genetic condition? Do they smoke? Are they on oral contraceptives, hormone therapy? So some of the things that we're going to do to prevent blood clots is early and frequent ambulation in the room, up and down the hallways, up to the chair when they're eating. We're going to make sure that they wear compression stockings after surgery or even before. All of our patients are going to get compression devices, with the exception of a patient who actually has a blood clot. We wouldn't put this on the affected extremity. Are these patients going to be on prophylactic medications to prevent blood clots? Sub-Q heparin, twice a day, every 8 hours? Or are they going to be on Lovenox sub-Q once a day or every 12 hours? Patients with clots, how are we going to prevent them from developing complications? We're going to administer early and appropriate anticoagulants for their approved diagnosis. We're going to review their patient's medication list to make sure any medications they're on, whether it's alternative medications, herbals, that they don't have any drug interactions with their anticoagulants, Coumadin, Lovenox, Xarelto. We know a lot of alternatives can either intensify the effects of anticoagulants or block the effects. We're going to monitor the appropriate laboratory levels associated with each lab and how it associates or affects the medication they're on. We know the PT and INR are in line with Coumadin or warfarin. We know that PTT levels are associated with heparin or Gatroban. In the event that a patient is having complications from blood thinners or anticoagulants, we might look at their H&H, their hemoglobin and hematocrit, to see if it's low. We also might look at their platelet count. Is it low in the setting of somebody who's on a heparin drip? Does that mean that this patient is heparin-induced thrombocytopenia? Or do they have an abnormal increase in their platelet count, which sets them at risk for clotting? So some things that we might do to monitor for and reduce the risk of bleeding is we're going to identify that there are specific populations that are increased risk for bleeding when they're on anticoagulants. And in some cases, these patients may not be put on anticoagulants. They may have to look at other treatment options. Patients who have a history of GI ulcers or peptic ulcer disease, they may not be good candidates for anticoagulants. We may not be able to put them on there. A history of recent significant bleeding, they may not be able to go on Coumadin or heparin. A lot of patients over the age of 85, they have decreased, they're frail, they're increased risk for fall. So could you imagine being on an anticoagulant and falling, the head injuries, the trauma that could ensue? Any patients that have hepatic or renal impairment or failure, these patients are at increased risk for toxicity on their anticoagulants because of their inability to metabolize and excrete the drugs. In some of our patients who are on anticoagulants, we want to be very observant for any signs of slight or obvious bleeding. We want to evaluate their secretions, their sputum, their urine. Is it blood tinged? We want to look at their surgical incisions to see, are they bleeding more than normal or normal that's indicated? Has it intensified since they've been put on this anticoagulant? We want to look at any type of insertion site or orifice to see if there's abnormal or intensified bleeding where there shouldn't be. We're going to look at their vital signs, especially in the setting of bleeding. We would see a low blood pressure, increased heart rate. And we're going to evaluate their mental status and level of consciousness. Patients who are at risk for bleeding also can bleed within their cranial cavity. Okay, so they can have hematomas, bleeding in the brain. So assessing for confusion or decreased LOC are indications of bleeding cerebrally. These are just some pictures of some abnormal integumentary bleeding or hematomas secondary to anticoagulants. So in the ambulatory and home care setting, things that we want to focus on for discharge teaching to modify these patients' risk factors. Patients who have blood clots may require elastic compression stockings for 2 years to help prevent that post-thrombotic syndrome, or to reduce their edema and to increase their circulation to reduce the recurrence of blood clots. We want to encourage all patients who smoke to stop smoking and to avoid any nicotine replacement products. They need to avoid constrictive clothing, crossing their ankles over each other, crossing their legs. We want patients who have had a history of blood clots to avoid any type of hormone replacement therapy. And any type of patient who we suspect might be at risk for a pulmonary embolism, we want to educate our patients of symptoms that they should be aware of to look for: difficulty breathing, rapid, quickly onset, quick breathing, pleuritic chest pain, so intensified, sharp chest pain, taking a deep breath in, cough, severe, quick anxiety, bloody sputum, like coughing up blood. These are all manifestations of a pulmonary embolism, and they need to call 911 immediately. Some other things is we want to educate our patients and caregivers about blood thinners and their possible side effects and their potential routine lab tests. So patients who are on warfarin or Coumadin, depending on how regulated they are with their INR level, these patients may be checked twice a week, weekly, or monthly, depending on how consistent their levels are and how good they are at managing their diet and their medications. They may have to go to the physician's office. They may go to a Coumadin clinic, or home care may be ordered to come and check these patients in their home. So these patients, we want to make sure that they maintain a consistent diet, avoid excessive amounts of vitamin K in the diet, green leafy vegetables. We know that can make it very difficult to get the Coumadin level or the INR where they want it. We want to avoid excessive vitamin E and alcohol. We know that can intensify the effects of Coumadin. Maintain hydration. We know dehydration can increase blood viscosity, making it an increased risk factor for blood clots. We want our patients to encourage them to lose weight. We know obesity can decrease venous return, increase venous pooling in the lower extremities, a prime setting for venous thrombosis. Patients should participate in exercise plans, but maintain safety precautions, especially if they're on blood thinners. We want to make sure that they're not participating in any dangerous activities or contact sports. In the event that somebody does have a blood clot in their leg even, we want to make sure that they're frequently and early ambulating to increase circulation. There hasn't been found to be any increased risk in developing a pulmonary embolism from early frequent ambulation. So when we're evaluating our patients, we want to make sure that their pain is well controlled. We want to assess their skin to make sure there's no ulcerations or no impaired skin integrity. In our patients who are on anticoagulants, we want to look for any indications or signs of hemorrhage. or any type of microscopic or occult bleeding, which might be from the stool. No signs of respiratory distress, which would be normal respiratory status, normal respiratory rate. No sharp pleuritic chest pain with inspiration or expiration. No hemoptysis or bloody cough. So let's talk about varicose veins. So varicose veins are the dilated, tortuous veins found in the saphenous vein system, usually in the superficial venous system. They can either be small or large, and typically the smaller ones, they're asymptomatic and they typically don't cause a lot of problems for patients. But the larger, more tortuous, obvious ones, they're going to have a lot more manifestations and implications for the patients. So there are two kinds, primary and secondary varicosities or varicose veins. Usually your primary or your essential are going to be idiopathic, so we don't know why they happen, but they're typically a congenital weakness of the superficial veins. They're more common in women. And the secondary varicosities are these that are going to occur secondary to a prior blood clot. So if somebody has had a DVT in their lower extremity, it's going to induce the development of varicosities. The smaller veins that are not necessarily painful, but they're more unsightly, are spider veins, and they're typically less than 1 millimeter in diameter, and they usually have a bluish-black color to them. So the etiology and pathophysiology. So varicose veins is going to occur when there's a dilation in the venous system secondary to increased pressure. And this is usually going to happen when our valve leaflets are stretched and they become incompetent. So this is going to allow blood to flow backwards instead of forwards, which is going to increase venous distension. So some of our risk factors is going to include a family history. So if your mother had it, you're much more at risk to having it. Female gender, smoking, obesity and pregnancy, and prolonged standing. So nurses, definitely any occupation where you're doing a lot of standing, nurses, waitresses, cosmetologists, these patients or these people, individuals are at increased risk for varicosities or varicose veins. So a lot of the manifestations, so if it's a small, really superficial varicosity, they're going to be asymptomatic. These patients aren't going to have a lot of discomfort. They're not even going to know they're there unless they see them. So it's going to be a cosmetic issue for these patients. But in other patients who they have larger, more lengthy, aggressive forms of varicosities, they're going to have an heavy aching feelings in their leg. They're going to have a lot of pain after standing all day, pressure, itching and burning, maybe some cramping. And in significant varicosities that have led to venous insufficiency, they might have edema, fatigue and restless legs, and sometimes they might even have nocturnal leg cramps that wake them up at night. So some diagnostic studies and collaborative care with people who have varicosities. We're going to do a physical exam, and we might do a duplex ultrasound just to see if some of these people who have the large varicosities, if they don't have maybe a superficial blood clot or any type of phlebitis associated with it, because the larger varicosities do place patients at risk for superficial blood clots and phlebitis. We're going to encourage these patients, especially those who have edema associated with the varicosities, to rest their legs with their limbs elevated, compression stockings, and exercise to improve circulation, to reduce the edema, and to reduce that pain. So some of the herbal therapies that patients with varicosities might try, which is listed in the book, is horse chestnut seed extract. It's a topical, and it actually is going to thin the blood and improve circulation. So some of the nursing considerations if a patient is using this is to avoid concurrent use of antiplatelets and anticoagulants. In some severe cases where more natural therapy hasn't worked with some of these varicosities, They might actually use venoactive drugs like diazepam, and it's been out there for a while. The diazepam actually strengthens the tones of the vessels, provides a little bit more stability and strength to maintain that vessel wall compliance. So it can actually help alleviate some of the symptoms associated with the varicosities, like the pain and the heaviness in the legs. In some patients who have maybe some of the smaller varicosities, where it's more of a cosmetic indication, they're going to have what's known as sclerotherapy. There's going to be an injection of a sclerosing substance into the vessel that's going to lead to the thrombosis and the sclerosis of the vein. So it's typically done in an outpatient setting or a provider's office. And then because they're actually injecting an irritant into the vessel to sclerose it, some of the complications are going to be pain, edema, inflammation, and then the risk factor for actual blood clot. So some other things that we might consider in patients with more advanced varicosities is laser and light therapy. This is going to work by heating the hemoglobin in the vessels, and it's also going to cause a sclerosis of the vessel, shrinking. Typically, their patients are going to receive more than one treatment at 6 to 12-week intervals. And some of the complications that you might see with laser and light therapy is pain, blistering, and increased pigmentation of the extremity. In severe cases and in more old cases of treatment for varicosities, patients are going to have vein ligation and phlebectomy. Sometimes this is more commonly known as vein stripping. It's indicated for patients who have varicosities where they have recurrent venous thrombosis, superficial, or they have chronic venous insufficiency. So some of the complications from removing these veins is bleeding, bruising, and infection. In 30% of these patients who have ligations and phlebectomies, a new vein will eventually form to replace the one that's been removed. And so some nursing considerations with vein ligation and phlebectomy is you're going to assess their circulation post-operatively, monitor the patient for bleeding, keeping their legs elevated, and they're going to wear elastic stockings. So some of the key management strategies for patients with varicosities is to prevent them. Okay? So we're going to teach our patients to avoid prolonged sitting or standing, especially if they have an occupation that requires this. As people get older, we're going to encourage them to lose weight and to maintain an ideal body weight. Walk daily, maintain exercise, maintain an active, healthy lifestyle. We're going to have them avoid constrictive clothing, avoid crossing their legs, crossing their ankles. And in the long-term management, we want them to do things that's going to improve their circulation, relieve their discomfort, avoid any complications such as blood clots or ulcers. And in some severe cases for the long term, these patients may need elastic stockings that need to be custom fitted for them. When they're sitting down or laying down, they need to keep their legs elevated above their heart, and they should frequently change their positions to maintain circulation. So chronic venous insufficiency and leg ulcers. So chronic venous insufficiency is a condition that develops when leg veins and their valves fail to keep moving. As a result of the backward flow or this venous congestion, there's going to be venous hypertension or venous pooling. And unfortunately, this over long periods of time, when it's severe, can lead to venous leg ulcers. Venous insufficiency is not necessarily life-threatening, but it can be very painful, debilitating, and a costly disease process. These patients are frequently dealing with edema, with leg ulcers that just won't heal. They're in and out of physicians' offices, trying different medications, different therapies, dealing with infections. Typically, these patients who have chronic venous insufficiency also have multiple comorbidities. They smoke, so they might have COPD. They might have heart failure. They might have high blood pressure. And so a lot of these patients who have severe chronic venous insufficiency, it's going to lead to impaired mobility and can lead to social isolation because their whole life is about managing this edema, these ulcers, and this pain. So typically patients who have chronic venous insufficiency, this is what their legs look like. And they're going to develop, if they develop ulcers, over their medial malleolus. So a lot of your risk factors for chronic venous insufficiency, we've already really talked about them. So people who have large congenital varicose veins, where they're already at risk for that pooling in the non-compliant incompetent valves veins. Advanced age. Patients who have had blood clots in their legs that were severe enough that caused a post-thrombotic syndrome. This is all predisposes patients to chronic venous insufficiency. So what it is the high venous pressures is going to cause blood to backflow into the venous system. Over time, the serous fluid is going to leak from the capillaries into the interstitial fluid. And if this is where we're going to see the massive amounts of edema in the interstitial space, and it's going to lead to inflammatory changes in the capillary walls. And so as fluid and serous leaks out into the interstitial tissue, the enzymes in our tissues are going to start to break down some of these red blood cells that have leaked out. And so over time, as our white blood cells, our macrophages, are going to consume the red blood cells that have been lysed or broken down from these tissue enzymes, they're going to release iron that's been stored in these RBCs and the hemoglobin. And this brownish discoloration is going to be released. And it's going to be known as hemosiderin staining. And that's a key finding in patients who have chronic venous insufficiency, is that increased brown pigmentation of their legs. Their skin, you're going to see, is going to become fibrotic, very thick and hardened from all of the edema and the inflammatory changes that happens in their lower extremities. Their skin is going to become leathery. They could have unilateral or bilateral edema. Most of the time you're going to see it in both legs. As a result of all of the edema and the stretching of the skin, they're going to have pruritus. They're at risk for eczema, so their skin's going to be dry, flaky, and peely. Like we said, because of all of the edema and the inflammatory changes in the tissues and in the vessels, they're more at risk for developing venous ulcers that kind of start from the inside and work out, most notably over the medial malleolus. They can have a lot of pain. It's typically going to be worse if the patient has an infection or an acute event, and it's going to be worse when their legs are dependent. In very rare cases, but not often, or very, very rare cases, do people with chronic venous insufficiency who have non-healing ulcers would have amputations. So a lot of the care we're going to be giving to these patients who have venous insufficiency, who are at risk for ulcers, is we're going to prevent these ulcers by using compression therapy to reduce this edema, to get it back up into their venous circulation, increase venous return to the heart. So these patients, because their conditions are so severe, we're not going to be able to just use the TED hose that we would use normal patients in the hospital. We're going to use custom fitted elastic stockings, which those are those two pictures up top. Ones are the zip ups on the slides and the others are Velcro wraps. And these are custom fitted, usually in wound care centers. They might be custom fitted by physical therapists, by medical supply stores, but they're custom fit to the patient's, their length, the diameter around their leg, and their conditions. So there's specific pressure just for them. In acute phases, when patients have an acute infection, wound, or edema, we might use a very short-term multi-layer bandage system to quickly alleviate the edema, and then we might fit them for a custom fitted stocking. And the multi-layer bandage system that you're going to commonly see is called an uniboot. And there's usually like a 3 or 4 layer wrap system that goes around the patient to compress, to reduce the edema, and to help heal the venous ulcer. Some of the dressings that we might use in somebody who has a venous ulcer with the venous insufficiency, we're going to want to maintain a moist environment. And usually with these patients, because they have such edema and open ulcers, they usually have high exudate. They usually have a lot of draining from their ulcers. So maintaining a moist environment is not an issue. So we might use dressings that can actually absorb a lot of the exudate. But some common dressings you might see with a venous ulcer are hydrocolloids, hydrogels, and foams. So usually you might see them used in combination with a multi-layer bandage system in the acute phases to help with the wound and to help with the edema. This is just an example of somebody who's got a venous ulcer and maybe some of the coverings that we would use as we're looking to heal it. So an additional collaborative care for somebody who's got venous insufficiency, these patients are also at risk for having peripheral arterial disease, or PAD. So we want to make sure that their disease process is not intensified by the therapy we're going to use for the vascular insufficiency. So we would monitor their ankle-brachial index, which we know is taking their systolic blood pressure from their ankle and dividing it by their systolic blood pressure from their brachial, and that would give us our ABI, or the ankle brachial index. And if our ABI is too low, we would not want to do compression therapy in somebody who's got venous insufficiency as well as PAD, because we can actually compress the arteries. Even though the patient's having a venous problem, we don't want to reduce the blood flow to that leg. So in addition, these patients who've got venous insufficiency with chronic ulcers, we want to evaluate their nutritional status to ensure wound healing. So we know in some of the research that deficiencies in protein, vitamin A, vitamin C, and zinc all contribute to delayed wound healing. So we're going to want to make sure that these patients are getting adequate amounts of protein, vitamin A, vitamin C, and zinc in their diet to enhance wound healing, to synthesize collagen formation, to improve DNA synthesis. So in a lot of our patients who have venous insufficiency with venous ulcers, preventative antibiotics are not indicated because most of these wounds are colonized. The only time we're going to start antibiotics is if we can actually assess for a localized infection. These patients are at risk for developing cellulitis or an infection in the subcutaneous tissue, so we do need to watch for that. That's an infection that will typically require IV antibiotics if it gets pretty progressive. We might want to consider culturing the wound if we're not convinced whether it's an actual infection or just colonization. And if it is a localized infection, we're obviously going to use systemic antibiotics. There's not any indication that supports the use of topical antibiotics at the site. So some other things, we're going to teach our patients about their compression devices. We're going to make sure that they can appropriately put them on and that they wear them daily. We also want to make sure that they're taking them off and that they're having them replaced every 4 to 6 months. When they take them off, we want to make sure that they assess their skin, make sure that there isn't any additional skin breakdown, and we want to protect the skin from additional trauma. To manage some of the eczema or the itching that accompanies chronic venous insufficiency, we want to make sure that the patient uses moisturizer or lotions to prevent cracking. These patients are also at risk for contact dermatitis or irritation from certain devices or products that they could use that could cause inflammation or further itching at the skin. So we want to make sure that they're using products that don't have a lot of fragrance or irritants in it. These patients should be Exercise to improve circulation, but also avoid standing or sitting for prolonged periods. And if they are sitting or if they are laying down sleeping at night, they need to do their best to have their legs elevated as much above their heart as they can.